Should it be routine practice to perform a YAG capsulotomy prior to lock-in? Can you explain what a YAG is and then why we might do it? And should we be doing it during the light treatment process?
Sure. Okay, so YAG it's an abbreviation. It's Yttrium Aluminum Garnet laser, and
Say
what
that
it
10 times
does.
fast.
Yeah, exactly. But a YAG laser. So what it does is, so when we put the implant in an eye, any type of implant, doesn't matter if it's light adjustable or not, any implant, we intentionally leave a very thin, clear membrane in the front of the eye that holds the implant. It's why the implant doesn't require stitches. It's held in place by its fit, and its fit is on this clear membrane. But it's living tissue, and over some period of time, that living tissue will start to lose its transparency. Typically within, as little as a year, sometimes as little as a few months, and usually within 3 to 5 years, virtually everyone requires a laser touch-up. And I describe it as saying, well, if you have curtains on your window, you don't tear the curtains down, you simply pull them apart. And so you pull the curtains across, and now you can see out the window. Well, it's the same thing with the egg laser. We don't remove that tissue that was clear and is now a little cloudy. We just move it to the side. So the question that was asked is, should we be doing that earlier in the process before we do the lock-in? And the answer is typically not, and for a couple of reasons. One is that during the healing process, that tissue, that clear capsule, is a barrier for some of the normal healing components that can cause swelling. And so we don't want there to be a free flow of those components into the back of the eye. That tissue creates that barrier, which makes it less likely for that to occur. Secondly, we want the implant to heal into place. I mean, there is some process by which the implant then becomes more firmly locked into place so that it can't and won't and will not move. And we want that process to continue. So the answer is we do the egg laser when we need to, not before. And I wouldn't do it prior to the lock-in. And so that is kind of the standard right now. Now, are there times when we do it before? Absolutely. There are types of cataracts that are very, very dense, that have fibrotic plaques. And that sounds bad, and it is actually. It means that we can't clear that membrane. We can't make a clear path. We can still put the implant in, but we know that there's this area that's going to influence the vision, and we will do a laser ahead of the lock-in in those situations. That's the exception, not the rule.
Yeah, nothing comes without risk with doing a YAG or any medical procedure. So I usually tell patients when they ask about it, because a lot of times people are doing their research and they know that a YAG capsulotomy is something that may need to be done. Um, I tell them that let's not do it until we need to do it. So there are points though in certain individuals where getting the refraction, when I ask you which is better, one or two, two or three, we do that test. If I can't get good responses from you, it's not because you're not good at doing that test. It's because you can't see them, and because you're looking through almost like a wax paper membrane, and that's when a YAG is something that we might need to do. So generally, we don't usually recommend it. Now, there are physicians that do, and there's different philosophies with this. I don't want to step on anybody's toes if they are doing it, or if you are a patient that had that done. It's not necessarily a bad thing. There's different ways to do things. But generally, we don't, because nothing comes without risk. We like to leave options on the table if we need to.